thank you all for joining. Either you're with us right now, or if you're watching on the YouTube channel, thank you for joining us. We held our first journal club in Cleveland in 2020. So I am very grateful for Dr. Valente, Dr. Steele, and the rest of the department for supporting that first one. And since then, we've done this for 3 years, which is exciting, and particularly for me, I guess, as a special place, given that both my wife and I trained in the Cleveland Clinic. So it's nice to see some friends on the call. It's quite special. As a testament to how big the department is, we've returned 3 times, and each time we have a different topic of discussion and a different special guest and a unique perspective. And today's special guest will be Dr. Mike Rosen, who's going to talk to us about abdominal wall challenges for the colorectal surgeon. So that's fantastic. As always, very grateful for the team, particularly for Dr. Galandiak, who oversees this. This is our disclaimer. As is a custom, I tried to quote a fun fact about Cleveland, and one of the facts is that it's the birthplace of Superman. But one of the other facts is that Dr. Valente is a wealth of knowledge when it comes to random information. And so I think there's no better person to have a few words about the city, the hospital, and the team. Valente is the director of training and a fantastic clinician. It may have his peak as the supervisor of training probably was in 2017. But I'm sure all the other fellows that came after are still getting some benefit from him. So please share with us about your hospital.
Thank you, Vlad. You're right. I think I did peak in 2017 with your class. You guys are all fantastic, but every class has been really great ever since as well. But you were my first class, actually. So thank you, Vlad. So this picture of Cleveland, I put this together with the help of some others over the years. We give this slide when the fellows come through, just kind of give a representation of some parts of Cleveland. We got the beautiful skyline there. We're on Lake Erie. We do have beaches. I like to include that there is we call it the North Coast here in Cleveland, Ohio, northeastern Ohio. Great Lakes Brewing. We're kind of like a Midwestern town. We like our sports. We got our Browns, our baseballs. I didn't show the Cavs on this one, unfortunately. This was post LeBron when I made this, and we're in the playoffs, but we lost again last night. So, anyways, we got the Guardians now, and our classic kind of when we have our fellows, when they used to come in for interviews, we would have a nice little party the night before, and we'd always have some kielbasa, some pierogies, very, very Cleveland style. We got a great national park here too, Cuyahoga Valley National Park, so a great place for outdoors. People don't realize it, but we do have a great outdoor environment. Vlad and his family, I know, enjoyed it. And obviously world-class orchestra, world-class art museum, and then world-class institutions like the Cleveland Clinic. This is an aerial view of the growth that is occurring over the last several years at the Cleveland Clinic. We celebrate our 100th anniversary last year, 1921, founded by 4 different individuals, 3 of them surgeons who were World War I veterans and colleagues of the Mayo brothers as well. So very interesting, unique, and storied place. A great place also that has one of the world's first departments of colorectal surgery. I always like to see there's not that many actual departments dedicated just to the discipline of colon and rectal surgery. One of the oldest started by Rupert Turnbull and then passed down to Dr. Fazio, and then Dr. Scott Steele today is our chairman. Our department right now fluctuates, between Vlad was there as well, about 21 to 22, 23 different staff at a time, or junior staff that are spending some extra time with us. Here's a glimpse of this year's class. And we also have the largest fellowship program in the country now with 6 ACGMA fellows. So they're pictured there as well. So a really dynamic staff who specialize in different aspects of colorectal surgery. But one thing that we, I think, uniformly and collectively gave up was taking care of peristomal hernias. So that's why Dr. Rosen is going to be on the call today. So we do everything there is to do in colorectal surgery, but I tell you, with the world-class hernia surgeons that we have here, it's nice to have those guys to do cases in conjunction with, where they do a lot of the mesh work and we do a lot of the bowel work. And in their own right, they're doing these big cases as well that we refer to them. So happy to have Dr. Rose and team online today too. So.
Thank you very much. So the next thing is we're going to have a poll, and the poll is related to one of the papers we're featuring this week, which is actually a Cleveland Clinic paper with Dr. Liska being the senior author on that. So if people can fill out what they think or what they do. So this is related to negative pressure wound therapy, Provena being the most common one that I know of for major colorectal surgery. And whilst we've got the poll, let's move on to paper number 1. The paper is called Prospective Randomized Study of the Use of Prosthetic Mesh to Prevent a Peristomal Hernia and a Permanent Colostomy, Results of a Long-Term Follow-Up. This paper comes from Finland with Dr. Tero Ratio being the supervising author. I'm sorry if I pronounced that incorrectly. The paper will be presented by Dr. Ayman Khan, and then we will have Dr. Liska to share with us his perspective. So thank you very much, Dr. Khan. When you're ready, please start.
Thank you. And thank you very much for the opportunity to present this paper at this journal club. So I'll move right on to the background. So the background to this paper, peristomal hernia is very common after forming a stoma. We all know that. Reported incidence between 32 and 93%. Meta-analyses of randomized controlled trials have shown that prophylactic mesh reduces the incidence of peristomal hernia. The most quoted randomized meta-analysis being in 2017. This informed the European Hernia Society's recommendations in 2017 that when a permanent end colostomy is constructed, prophylactic mesh should be placed. However, a problem with a lot of the randomized controlled trials is that long-term efficacy of use of prophylactic mesh is lacking. And so this is where this paper comes in. Next slide. So this was a long-term trial of an initial randomized control trial. It was set in Finland across multiple centers. It was a randomized control trial of prophylactic peristomal mesh placement at the time of abdominal perineal resection for low rectal cancer. There was 2 groups. The intervention group had a laparoscopic placement of a prophylactic keyhole intraperitoneal onlay mesh, which was the Dynamesh, which is a non-absorbable mesh with a visceral coating. And the control group had no mesh placement. And this particular study looked at 5-year outcomes of the original randomized controlled trial. So the outcomes that were reviewed were, the data was sought from 2 different sources. Firstly, all the patients in the initial randomized controlled trial were invited back for clinical review, and a number of factors were reviewed. Firstly, stoma-related problems. All patients were examined for clinically detected peristomal hernia, and all patients were imaged to identify radiological peristomal hernias. And the second source of outcomes was that all the patients in the original randomized controlled trial, their medical records were searched to look for stoma-related complications. Next slide. So the results, firstly, all the patients that were invited back for clinical review. So in the initial randomized controlled trial, there were 35 patients in each arm of the intervention and the control group. In this follow-up study, at 5 years, there were 20 patients in the intervention group and 15 patients in the control group that were included. And a number of different outcomes were reviewed, and there were no significant clinical differences in clinical outcomes or CT detected hernia rates. And this table just shows the number of different outcomes that were reviewed, include incisional hernia, peristomal hernia, and any complications. So there was no difference between the 2 groups. Next slide. The second source of outcomes was chart review. And one of the key outcomes that we looked for was how many of these patients, including the original randomized controlled trial, required subsequent peristomal hernia repair. And in the mesh group, 1 out of 35 patients required peristomal hernia repair. And in the control group, 6 of the 35 required peristomal hernia repair. And this was a significant difference. And if you look at the Kaplan-Meier curve of peristomal hernia-free survival, you can see that most of the patients who required peristomal hernia repair in the control group required it within the first 2 years. The mean time was 14 months. And in the mesh group, the one person who did require parastommal hernia required a long time later at 40 months. Next slide. So based on these findings, the authors concluded that prophylactic laparoscopic placement of intraperitoneal keyhole mesh significantly reduced the incidence of parastommal hernia repair with no increase in mesh-related morbidity. However, they did note that the results are subject to bias due to small sample size and dropout from the original randomized control trial.
Thank you very much for this great summary. Can I now please get Dr. Liska to say a few words?
Thanks for having me, Vlad. It's great to see everyone again. Just, you know, as disclaimer, like Dr. Valente said, we send all our hernias to Dr. Rosen. So I'm definitely no expert on parastommal hernias. In terms of reviewing this paper, I think Eamon did a very nice job summarizing it, and it's a very interesting paper. And you know, like everyone knows, it's very hard to do randomized controlled trials, surgical randomized controlled trials. The only one who's good at it is Dr. Rosen, probably. So, but it's hard to do these trials, and to have long-term follow-up is even harder. So this is long-term follow-up, and you know, the first thing that struck me was, you know, they started off with 70 patients that were randomized, and the number of patients that were left to be analyzed were 35, so half. And then, you know, what's interesting is that a lot of the patients that dropped out were due to death, right? And again, this is important to realize when you're talking about doing a mesh in patients that are undergoing APR for rectal cancer, that a lot of these patients won't be alive in 5 years. You know, it sounds like, you know, a mortality rate as high as this paper sounds, you know, a little odd to us when we're doing rectal cancer care, but we all know that patients requiring APRs usually do worse long-term than patients that undergo low anterior resections. So the number of survival is when you think about it, is not that shocking. And that's something to keep in mind when thinking about putting a permanent mesh in someone and thinking about long-term outcomes. And when you're talking about a patient who has a very low rectal cancer that needs an APR. So I think that was an important sort of take-home message that wasn't fully spelled out, perhaps. Then, you know, in terms of the conclusion of the paper, what I had a little bit of an issue with was really that the final conclusion was that the mesh is worthwhile because it lowers the need for surgical repair. Now, nowhere in the methods was the need for surgical repair defined as one of the outcomes, right? All the outcomes, Eamon, that you summarized, if you want to go back, oh, I don't know if we can go back to the slides, but the need for requiring surgical repair was not one of the predefined outcomes. But it ended up being, you know, the only outcome that was significant. Yeah, if you go one further, where were the outcomes? I thought we had a slide. Yeah, outcomes, there he goes. So stoma-related problems, pain, leakage, bulging, skin, bowel obstruction. Here's one need for reoperation. Examination, clinically detectable parastomal hernia repair, and stoma complications. And then CT imaging, which is a very important outcome to look at when we look at all these hernia studies, that we're not just looking at clinically detectable hernias, but we're looking at hernias seen on CT scan. And the number was not different between the mesh and the non-mesh. But needing repair of the hernia was not one of the outcomes defined. And then, you know, when you had the Kaplan-Meier curve, you said surgical repair required. Now, we all see lots of patients with parastomal hernias. And then how do you define if the repair is actually required? You know, that's, again, the paper didn't tell us necessarily. They said the indications for the repairs, but we can't really tell those patients who didn't have repairs, how many of them had similar symptoms. Now, if I see a patient with a parastomal hernia and they have a mesh already in place, I, as a surgeon, you know, unlike Dr. Rose, maybe, I'm less likely to go in for a repair in somebody who already has a mesh in there. That repair is going to be a lot more complicated than in somebody who never had a mesh in there. So I wonder if there's a significant bias on the sides of the surgeon who was seeing these patients in follow-up in terms of who they actually took for a repair of the hernia. So yes, the ones without a mesh had a higher rate of having surgery for their hernias, but maybe the surgeons were less likely to operate on patients with hernias that already had a mesh in it. So I think that's one bias that could potentially skew sort of the result of this paper. And besides the limitations that the authors discuss in terms of, this small sample size. But, I want to congratulate the authors also, because it's very hard to do randomized controlled trials and get such a long-term follow-up and sort of report all the data that they collected very carefully. So those were my observations.
Thank you very much. We're actually quite fortunate to have one of the authors with us, Dr. Elisa Makarainen. I'm sorry if I pronounced that incorrectly. I have no idea what time it is in Finland, so thank you for joining us on the call. Would you like to say a few words, particularly how this paper may have changed the practice in your institution?
Hi, it's thank you for having me here. It's a great pleasure to participate, and I definitely agree with the comments on the article. We do have some serious limitations on the data. I could comment on the dropout rate. It's the patients were quite old with a severe disease, and all the dropouts were justified by the death or the fragility of the patients. But I definitely agree that we need to be cautious of the mesh we put in the patient, but all the parostemal hernias were repaired quite early in the path, so the median repair time was 14 months. So the parostemal hernias that were symptomatic came out quite early.
Thank you. Now, I've got a few questions of discussion topics. If anyone in the audience wants to ask anything, please put it in the chat. The first thing I've noticed that I personally haven't done was in the methods the authors comment about using a Valsalva technique to detect hernias. Dr. Rosen, is that something that you ever find useful?
It's not something that we typically do. In clinical trials, kind of trying to get at the heart of what is your primary outcome is important. In peristomals, obviously, the reality is we don't even have a great definition of what an actual anatomic recurrence is. And particularly in peristomal hernias, it makes it challenging to assess all these things. I really agree I thought David's comments were very insightful in that, if there's just telescoping of the loop of bowel that was going through that hole, but there's a little bit more up there, that might be an indication for some people to repair, perhaps not for me. If there's just a little bit of momentum, does it need to be another piece of bowel? So obviously, if you do a prone CT or Valsalva, you probably will increase the sensitivity of the test. Still, though, it gets to the heart of the matter of, what problem are we trying to fix? Because, I would just comment to David's point of, we certainly fix a lot of peristomal hernias, and I think we're experts at not getting great results with peristomal hernia repairs. This is a really hard disease. And certainly if you look hard enough and you want to find recurrences, it's probably more common. The only other comment I'd make, just while I got the mic here real quick, is just to add one thing to the kind of presentation. There's actually been 2 randomized controlled trials since the kind of prelim data for this. There's the Grecar, and I think it's the stoma mesh trial, because there was a lot of excitement about preventing peristomals, and both of those were negative trials and showed no difference between mesh and no mesh. And I think it was over 200 people in each trial. So I think it's an unknown answer. It's hard to define these things. And so, again, peristomals, defining them, indications for repair are difficult to fit into a clinical trial, and I think are more exploratory than kind of primary outcomes, which is what I think, this paper was meant to do.
Thank you. Next point I wanted to raise was shrinkage. So shrinkage of mesh is a recognized thing. Obviously, different prostheses have different extents of shrinkage. How does this work in a keyhole mesh repair? Does that make the keyhole defect smaller or bigger? And if it makes it smaller, is there a delayed risk of stricture formation and therefore fistula? Is there any data or any views on that?
First of all, the Dynamesh that was used in this trial, I don't think is available in the United States. So it is a little bit of a different type of mesh than what we typically use. And there are some, I would say, theoretical kind of basic science type concepts as far as tissue incorporation and reaction to the mesh that I think people will promote, but we don't have access to it. I'm almost certain it's not available in the entire US. So otherwise, I would tell you that shrinkage of mesh is commonly discussed, but is often from a fundamental kind of misrepresentation of the original data. A lot of shrinkage data where people say mesh shrinks 30% actually comes from animal studies where you're putting in, 2-centimeter pieces of mesh, and just to actually accurately measure 30% shrinkage, not just wrinkling of the mesh due to technical issues, it's really challenging. So just on a personal note, I would say shrinkage of mesh is often overemphasized, but to your point, specifically about peristomas and keyholes, I always tell people there's a really easy experiment. If you take a burger patty and you cut a hole in the middle of that burger and then you cook it, the hole actually gets bigger because the material shrinks within the material, not that the hole gets smaller. And so keyholes often suffer not from getting larger and recurring. The erosions from keyholes tend to be earlier and are more of a technical problem where you're kind of kinking off the stoma and almost scissoring the stoma, and you can get obstructions. And so I don't think that shrinkage leads to erosions. I think a technical problem with the way the keyhole was placed, and you certainly can see erosions with any prosthetic around the bowel. So I think it's a real risk, but probably not because of shrinkage. And I only say that because one of the questions about keyholes is kind of how tight do you make that keyhole? And that's another art, not science. And my answer to that is just tight enough where my colorectal partners are uncomfortable. That's about right where you want it, where they're a little cringy. And Dr. Hall kind of puts her fingers in there and rips it open. That's right where you want it.
Thank you. Well, to that effect, I guess particularly in Cleveland, there's a number of end stomas made for Crohn's disease compared to cancer. And so that's a different disease process. Arguably, erosion certainly is more of a concern. Is there a contraindication to particular types of hernia repairs, or certainly with prophylactic mesh, based on the disease process of why the stoma is made?
Yeah, so I would just say in general, my personal opinion on prophylactic mesh is it's probably not a great idea in peristomal hernia creation. I think beyond just Crohn's, ultimately it has a fairly high recurrence rate in most studies if you really kind of get everything matched up, and there's clearly a risk to mesh around the bowel. And I think for the reasons that David kind of said, peristomal hernias are hard to fix and they're a problem. If we could prevent them, that would be great. But mesh can be a problem as well. So balancing, trying to prevent a problem by potentially introducing a problem. And I think in this trial, you see it done by experts, the results can be great. But when you start to kind of promote these things for routine use, and then you add the other issue, which is in the US, they will be resistant to putting synthetic mesh. So you're really talking about biologic or absorbable synthetic meshes, which are, can be $10,000 to $20,000 of cost for something prophylactic. I think it's tough. Crohn's specifically, I think you have to be careful because obviously I'm preaching to the choir. Crohn's bowel is unforgiving, and any technical issues or any mistakes, you will pay the price, and you might not pay that price till much later in life, but it will be a high price. So I would never put prophylactic mesh around a stoma. If I was, especially a Crohn's stoma, if I was repairing a hernia, it would be a different story, and probably, I mean, I don't think we know the answer specifically around Crohn's, how safe or unsafe it is.
Thank you for that. Can I, Dr. Makarainen, just a follow-up question for you. So in Finland, are the views different to the States? I know that the mesh is different. When would you sort of place prophylactic mesh?
Actually, we do use prophylactic meshes on a routine basis. We put a mesh in for every patient. We operate for abdominal perineal resection for cancer. We do not use the keyhole technique we used in this trial because obviously it does not work very well, but we do use the Dynamesh IPST, the funnel-shaped mesh. Actually, we are publishing our results of RCT using Dynamesh IPST, which is the 3D shaped funnel-shaped mesh. The results will be published next week at the EHS meeting in Barcelona. We do use the prophylactic meshes on a routine basis. And actually, we do believe in them.
That's interesting with the funnel mesh. Are you comparing it to tunneling the bowel laterally then?
No.
Is that the control or?
It's an RCT, a multi-center RCT where we put a mesh in for intra-abdominal space and compare the mesh patients to controls without the mesh.
Okay, thank you. Well, I know a good journal that would be interested in this study, I think.
Good to know.
Okay, well, I think this is great for this first paper. Let's move on to the second paper. The second paper is called A Surgical Repair of the Postoperative Perineal Hernia, a Case for the Perineal Approach. This paper comes actually from the host institution, with Dr. Gorgon being the senior author. It will be presented by Dr. Will Chapman, and then we'll have Josh Sommervilla to say a few words. Thank you. Please start when you're ready.
Thanks so much for having me. I apologize for my casual dress. We are coincidentally in the midst of a peristomal hernia repair that had a few surprises. Next slide, please. As Dr. Bolshinsky mentioned, this is a paper from the Cleveland Clinic, single center study that really was trying to get at a couple of questions around a relatively rare complication of APR. Perineal hernias are a protrusion of the viscera through the pelvic floor. The incidence is debated throughout the literature, but most articles tend to settle on a number somewhere below 10%. Our own center in a previous paper found about a 1% incidence of perineal hernias. And, you know, the typical symptoms of these include bulges, pain, and most concerningly, bowel obstructions. But because this is such a rare process, there's a lot of debate about several factors of treating these. You know, one of the biggest ones is how to approach them. And then others are with regard to whether or not closure adjuncts should be used, what kind of suture or other fixation devices or techniques should be used in closing them. And then really a lack of understanding of what the common complications and ultimately the durability of these repairs are. Next slide. So this case series of 36 patients was intended to try and get at some of these bigger questions. As I mentioned, this is a single center retrospective study. This looked at patients who underwent perineal hernia repair from 2009 to 2019. And though that's a broad time range, the majority of these surgeries were performed after 2017. All patients included in this study underwent a perineal hernia repair, and several outcomes of interest were reported. Obviously, recurrence and 30-day complications, but also length of stay and several other descriptive factors with regards to the types of repairs and how they were performed. And as you can see in table 2, I think it's worth mentioning that there are lots of variability in both the approach, whether or not mesh is used, and exactly how the mesh is used. And the authors did an excellent job of really demonstrating that wide variability of technique. Next slide. I won't go through all the results, but I thought this graphic from the paper was particularly illustrative. You can see that the majority of patients underwent a perineal approach at 61%. And of those who both underwent perineal or transabdominal approaches, there was significant variability between, within groups of exactly how those repairs were performed. Notably, the length of stay was significantly shorter among the perineal hernia group, and that is, somewhat obvious. But these repairs are typically more limited in scope. They obviously don't transect the abdominal wall, often are accompanied with less small bowel manipulation, and thus have a much lower risk of postoperative pain problems as well as postoperative ileus. It's also worth mentioning that the recurrence rates in both of these groups was about 20%. No significant difference between either the perineal or transabdominal approach. And this was also relatively standard amongst the literature as well. Next slide. The authors draw several important conclusions from these 36 patients. First of all, they recommended that a perineal approach should be the first approach considered, but certainly they were not prescriptive in exactly how a surgeon would address this problem in each individual patient. And they noted several complicating factors that should also be considered. For example, patients that have multiple hernias will often undergo a transabdominal approach, as that will allow the surgeon in one setting to address both the perineal hernia as well as a peristomal or other hernias that may exist. Second, though the authors found a difference in length of stay between the two approaches, there was no difference in long-term outcome or complication, as demonstrated by that figure there in the lower right. And finally, the authors recommended that mesh should be used with either approach anytime a perineal hernia was being addressed. And they commented on several considerations when picking the type of mesh to be used, but there really is no good data in how mesh selection should be performed. It is interesting in this group, the majority of meshes that were used were synthetic meshes, and most of them were coated. That's the conclusion of my presentation. Thank you.
Thank you very much for that summary. If I can now get Dr. Somavilla to comment. Thank you.
Yeah, hi. Thanks everyone for having me here. So I think this is a really interesting paper about an uncommon problem, but one that we definitely see with some frequency, and one that is, as opposed to the topic discussed in the last paper, something that's just uncommon enough that we're probably not going to get more definitive data in the form of randomized controlled trial about, not just because of how common it is, but because of the variety in not just approach, but in techniques that we use to treat it. So, this paper is a pretty large case series considering the problem that it's addressing, and it purportedly compares the approaches of transabdominal versus transperineal, but it also includes within those groups a lot of different techniques, and I think most importantly, the presence or absence of musculocutaneous flaps to reinforce these repairs, which could be as big of a factor in their success as the approach itself is. I think, like papers of this type, its main utility is in giving us some good data to discuss with our patients when we're considering this type of operation of what they might come to expect as far as their hospital stay and their risk of recurrence in the future. And I think the conclusions are valid in that, given the lack of clear benefit to a transabdominal approach, I think it's intuitive to take the lesser approach prior to considering more major operation. And like Dr. Chapman mentioned, I think there are a lot of additional considerations that may, in certain situations, make you want to go straight to an abdominal approach. A lot of those might have to do with the hostility of the abdomen at the original operation, and other factors having to do with the surgery that led to the development of the peristomal hernia. I think it'd be really interesting to have more information about the factor of to what degree flaps helped, but then there's going to be a lot of selection bias with that, because probably we're using flaps for the more significant perineal hernias that are probably more likely to occur.
Thank you. In relation to the flaps, I noticed that as well. So I couldn't clearly identify if any of the patients who required a perineal hernia repair had a flap closure in the index operation. So there was a comment about using a flap, I guess, for the hernia repair. In your experience in the department or in the adjoining department with Dr. Rosen, do perineal hernias occur clinically after a person's had a flap closure of the perineum?
Yeah, I recently had one of these. There's no question about it. It's, remember, a flap closure, we go back to the reason that this is all varied in many cases, in my opinion, is because a lot of these patients differ, and it differs in terms of maybe what plastic surgeon you deal with, the hostility of the abdomen, the underlying comorbidities. But one of the things, Vlad, that I think that goes into play is how much, if they're doing a flap, of a bulk of a muscle do they have, and what's the defect? So just because you may quote unquote fill the pelvis with a flap, in some cases that they're using a VRAM, maybe they've had an ostomy there in the past and you can't use the whole muscle, or if it's a gluteal thing that you kind of fold in. So the defect doesn't always match the flap that you're using. And when people have poor tissues and then subsequently have a wound infection or a perineal infection, that can worsen things as well and be a setup for having a perineal hernia, even in the setting of having prior muscle flap.
Thank you. The other question I have is in relation to the technique of mesh fixation, which, and particularly that would be different in men and women in a way. Obviously, it's different if a person's had an exenteration. But based on this technique, where would you secure the mesh, and how much of an overlap do you aim for? I'm not sure who can answer that question. Dr. Steele, maybe what would you do?
Yeah, I mean, so a couple of things. So obviously, when you do these APRs, and you take the levators and you do, an ELIP type approach, you don't have a whole lot that's there. I think in some cases, and Mike can comment on this as well, coming in and putting in some sort of mesh at the pelvic inlet, you have the sacral promontory in the back and kind of going around and tacking it in the front. That is one of the things that is maybe a little bit more common. From below, and sometimes it's flatus and moonbeams that you're trying to get it to. You have things that are laterally, the lateral pelvic sidewall, you got to watch out depending on what your level is for some of the internal iliac branches. But in many cases, you do have a rim kind of as you come into that. But really with these wide defects, and especially with a exoneration, you may have a lot of difficulty in getting that if you're not just kind of just sewing it to whatever's there. Mike, any thoughts there?
Yeah, no, thanks. I do mostly abdominal approaches. So like Scott said, pelvic inlet and kind of putting the mesh there on the sacral promontory, et cetera. Posteriorly, some folks, when they do the APR, they put the mesh in right away. I know like Rodrigo Perez down in Brazil does that, where they automatically do a coccygectomy and put in a prophylactic piece of mesh right away. So I don't have much experience from down below, but as Scott was saying, you kind of have, at the ones I've seen, you kind of recreate that pelvic floor bit. You kind of you can put it to the sacrum or the tip of the coccyx. It's still there, kind of in the ostium there, and then where the levator should be gone, there is some hard tendon type material there and some bone there. So, but anteriorly, I agree, it's kind of tough to. What was that? Flatus and moonbeams. What was that? Unicorn, flatus, and moonbeams. I think that's what it was. Anyways,
I'll just weigh in for. I think. I mean, first of all, where to fixate it is where Scott tells me it's safe to fixate it. Like down there, I'm a little lost. So I will say it is a challenge. I mean, listen, it's just by seeing over that amount of years, the amount of APRs done at the Cleveland Clinic, like it. I should say it's an uncommon problem that gets to the OR. How common it is a little less clear, because I think a lot of us, including myself, when I see these people really try and talk about a surgery, and see if they could live with it at all. The one thing I would add is I thought this paper was interesting to just kind of show the varied aspect of it. And I think the general consensus of, look, if it's small and you can go from the bottom, so be it. But the other issue is a lot of these people have a concomitant peristomal hernia, midline hernia, maybe issues after their VRAM that are driving the midline approach more than even the perineal defect. So I know I've done a couple with Scott where we go in at the same time and he'll deal with the perineal, and then I'll go ahead and fix the anterior hernia at the same time. So I don't know if that was excluded, but I do think this is not randomized controlled trial things, because each one of these is unique, they're uncommon, and they really, I think this requires more of the art of thinking about the whole picture. My currently favorite operation to do here is if they don't already have a VRAM, and kind of to Scott's point, if it's like a bulky rectus muscle, is to put a VRAM down there, fill the space, plus or minus mesh, and then kind of quote unquote prophylactically or address the abdominal wall with a large piece of synthetic mesh and address the hernia as well at the same time. It's a big operation. I've done it a few times for big perineal hernias and with some reasonable success. But I think this is not a one size fits all. I think this really does require colorectal kind of hernia folks and plastic surgeons to all weigh in, look at the patient, look at the defect, and kind of do the right thing.
It almost sounds like you can secure the abdominal mesh to the perineal mesh, the way you're describing it.
Close.
Thank you. Can we move on to the next part? So we have the results of the poll, which Stephen shares.
Yeah, so this was the question was, do you use negative pressure wound therapy for major colorectal surgery? There was no one that seemed to use it routinely. So we had a 0 always, but there was a preponderance of people, and this is a 66% response rate, and that use it sometimes. Then the 30% rarely, and then a handful of people are never. Not sure what other would be.
Thank you. I guess the paper, the third paper that we featured this month about the effect of incisional negative pressure wound therapy on SSIs does also come from Cleveland, where Dr. Liska is the senior author. So perhaps, Dr. Liska, when would you use it, and what have you learned from the study about negative pressure wound therapy?
Yeah, so I think, again, the number one lesson was similar to what I said before, that doing randomized controlled trials in surgery is hard. And it took a long time to get this one done. We had 300 patients, and it took a long time to enroll all these patients. The study was actually initiated by Dr. Ramsey. Back then we had some initial promising data that the negative wound pressure, incisional negative pressure wound therapy, or the Prevena vac, would actually prevent surgical site infections. And the way we designed this trial was to use it in the patients where we thought that the risk of a wound infection was absolutely the highest. So if you look at the trial, it was the majority of patients had redo pouch procedures, right? So extremely complicated surgeries. Patients would start with a stoma, end up with a stoma. I think 80% of patients in the trial had stomas. So again, a very sort of high risk group of patients. And the reason, again, why we use that is one, from a power analysis standpoint, we thought if we can sort of load the boat and have the highest sort of pre-test probability of developing a wound infection, that would help us with our trial. But also because we know that the Prevena is not a cheap device, and it's also a nuisance to the patient, right? They have to carry that piece of equipment around with them, and usually have them in the hospital for a long time. So it made sense to look at it in such a very high risk population. And what we found was that there was no statistically significant difference in the development of SSIs. And we looked at superficial surgical site infection, deep surgical site infections, organ space. We looked at everything, and we didn't find any statistically significant difference. We tried to look at even, some subgroups, high BMI versus low BMI, and we still couldn't find anything that would really convince us that the Prevena was doing something significant. And so our conclusion was, that it doesn't work even in this high risk population. And again, because of the high cost associated with it, my take home message was that I was not going to routinely use it. In the poll, my answer was sometimes, so I still will use it rarely, but definitely not as frequently as I used it before we had the results of this trial.
Thank
Dave,
you.
you've got a lot of books behind you. I just noticed that.
They're all fake. They're just covers.
Thank you very much. So unless anyone has any other comments, and if you do, please put them in the chat, might move on to the next segment, which is our special guest segment. Of course, Dr. Michael Rosen is the special guest. He's a world-renowned hernia expert. He received his medical degree initially from the University of South California School of Medicine and has been in practice for over 20 years. He's had his residency in Massachusetts General Hospital, and then 2 minimally invasive surgery fellowship, one in the Cleveland Clinic and one in the Carolinas Medical Center. As I understand, he was appointed to the Cleveland Clinic in 2014 and has built a very successful and highly complex hernia service. So we're very fortunate to have him. Thank you. Now, if it's possible, I want to start our discussion kind of around the study that you published last year. I think biologic versus synthetic mesh for single-stage repair of contaminated ventral hernias, a randomized controlled trial. It was published in JAMA, which I guess nobody's perfect. All I can say is that we have a better journal club.
I'm coming.
And so it's a very interesting and useful paper. The first question I have about it is, you have a 2-year cutoff for hernia recurrence. And so do you think this is the gold standard cutoff when we measure recurrence, whether it's peristomal hernia recurrence or incisional?
I don't think it's the gold standard. So I think I would say the one thing about hernias is there's no end of follow-up. Clearly, if you follow hernias long enough, recurrences will still occur. I think in general, I think for clinical trials, you obviously can't go on forever, and kind of for primary endpoints, I would say that 2 years probably tells 85% of the story. And it gets you close to the truth, but you need longer term follow-up. I think certainly 5 to 10 years is where we get to see potentially some of the long-term, less frequent, catastrophic potential complications. But I think, most of the story is by 2 years. Peristomals, I think probably 50 years isn't enough study time for, if you live long enough, it is likely that you will have a hernia around your peristome no matter what you do.
Thank you. In your conclusion, you really don't mix words. You say synthetic mesh demonstrates superior 2-year hernia recurrence risk compared with biologic mesh, with both mesh demonstrating similar safety profiles. And then you say the price of biologic mesh was over 200 times that of synthetic mesh for these outcomes. Now, I guess being a devil's advocate is of sorts. How do you manage mesh infection, particularly with permanent mesh?
Yeah, so this is a great question. And, I think, first of all, that is always kind of the fear of synthetic mesh, is that if you were to get an infection, kind of what is the cost to that? What is the reoperation rate to that? And all the downstream effects that happen to that. The reality of this trial is that never really happened, where we had to go back and take out an entire piece of mesh. Now, there's a lot of reasons for that. It can be that, like most clinical trials, it was done at expert centers of people who do a very high volume of this. This was a multi-center trial, but all of us were fellowship trained. All of us do this stuff all the time. So the reality is the low rate of mesh infections and the lack of need for mesh removal might be more related to the technical expertise than the mesh material itself. However, I would say that one of the things that we've learned is particularly the larger pore meshes, often when they're placed in the retromuscular space, as they were all in this trial, if you get an infection, and even if it involves the mesh can granulate through that infection and you can retain the mesh. Or what is more often the case is you have to go back and remove a small piece of unincorporated mesh, which in this trial kind of really hasn't happened. We're actually going to publish 5-year follow-up to kind of address, because I think that's more of the window of that type of thing. And the only other piece I would add is just like probably to say, like, you know, the reality is Crohn's disease is a very broad term. For colorectal surgeons, you know that there are all different subsets of Crohn's disease of severity and all this. When we talk about permanent synthetic mesh, a lot of the fear, which is why we did this trial, of permanent synthetic mesh is based on historic kind of composites mesh, where there was PTFE mesh, which PTFE mesh works well, but if it gets infected, it all has to come out. And what we've learned through our work with this is that a lot of times you can treat these and you're able to retain, if not the entire piece of mesh, you know, the overwhelming majority of it.
Thank you. That's very useful. Now, in your opinion, and you may need a magic wand for this, but how is there a way to prevent peristomal hernias, or are there techniques that you use that you think reduces the risk?
You know, like I said earlier, I think that there was a lot of excitement about mesh, prophylactic mesh preventing peristomal hernias, and I'm encouraged to hear the talk earlier tonight that hopefully maybe we can get there. The reality is, in most of the large scale randomized trials, it really just hasn't been able to show a benefit. And I think coupled with what I know about fixing peristomal hernias, and that often includes resiting the stoma and kind of setting up a somewhat prophylactic situation. The results aren't great. And I think that, you know, where we set the bar of success, if a 70% success rate is considered good, then I think we're probably about there. But, you know, I think no matter what you do, no matter how you put the mesh, no matter what mesh you put in there, if you follow these people up long enough, they're all going to get it. And I in the world of peristomals, just me personally, and again, I'm incredibly lucky, like all the tough colorectal surgery is done by our colorectal surgeons. Like I don't have to live in this space, but the majority of people who are getting stomas now, maybe outside of the APRs, which I think is even a smaller group of people than it used to be, these are sick, complex people. And I think that the thought of putting in mesh, adding complications, taking that risk, when oftentimes you're just trying to get that bowel up there and get these people through these operations, is not worth it. And just leave the peristomal hernia down the road. We can fix it electively. And again, we're not perfect at it, but I think that, you know, we've gotten good enough where we can get people through the operation. So I'm not sure it's worth the upfront risk to prevent a treatable problem in the space of people who are getting peristomal hernias now. Is you know, if I could give a message to colorectal surgeons, I think I might not worry too much about the peristomal hernias. I mean, most of the time they don't need to be fixed. And if they do, we'll fix them.
Mike, it's Scott. Can you talk a little bit about use of synthetic mesh in apposition to the bowel itself? Erosion, is it a real thing? Is it not a real thing? You know, with these keyhole meshes, should there only be a certain type of mesh we're using, or can you treat through this if, God forbid, there is infection? You've done a lot of work in that space. Can you give us an overview on that?
Yeah, so in the trial, Vlad, that you mentioned, the biologic versus synthetic, because these were all clean contaminated cases, it turns out that I think of the 250 cases, 108 were actually peristomal hernias. So we actually did another post hoc sub-analysis that was recently published in JACS of those patients. So, and they were biologic versus synthetic. And a couple of things I would say about that, to kind of Scott's point, is there were 4 erosions in the trial. 2 of them were with synthetic mesh and 2 of them were with biologic mesh. So You can get erosions with whatever mesh you use. And the vast majority, in my opinion, of erosions, and some of those were mine, were technical issues, where when you have a large midline hernia and the stoma, and as you're putting tension, closing that midline and trying to get kind of three tight layers, a posterior sheath, a mesh, and an anterior sheath, and a piece of bowel to come straight through those layers, it's technically challenging. And you could easily offset that where you're kind of kinking off a stoma. I think that's erosion issues. I don't think it matters what mesh you use. If that happens, you're in trouble. So I think a lot of attention to not kinking the stoma. I would say of the erosions that we had, all of them went back to the OR. All of them had revisions of their stoma. And in that scenario, at least taking out the area that was involved was required, but often the incorporated mesh we could leave behind. I personally, again, I don't think it matters what mesh you put there. All mesh can have issues, and we prefer to put synthetic mesh because it's less expensive. I'll just throw it out there. Maybe I'll come back to you guys. Now I know you guys like peristomals. I'll just put this little tidbit out there. We have actually completed, and in about 6 months we'll be done with the 2-year follow-up. We've randomized 150 patients to retromuscular keyhole versus retromuscular sugar baker, all with synthetic mesh. So it's 75 in each arm with 2-year radiographic follow-up. So we'll have a good idea of mesh-related complications out to 2 years and recurrence rate. So we don't know the answers yet, but I think that the sneak preview is recurrence rates are higher than we all wish. Mesh complication rates are fairly low and are almost always technical, and it probably doesn't matter what mesh you use.
Thank you. I'd like to briefly, and it's difficult to do this briefly, but cover two sort of scenarios related to the abdominal wall management for colorectal patients. One is the colorectal patient who's had a flap previously. And so how does a hernia or a weakness of the abdominal wall in someone who's had a, I don't know, VRAM flap or something, affect you? And also, what are the difference in the management from a mesh perspective? And the other one would be the management of a abdominal wall defect because of an enterocutaneous fistula.
Okay, so the VRAM flap, let me take that first. I think anytime there's missing tissue, I think the first thing to do is separate out, is it a hernia or a bulge? Unfortunately, in the world of colorectal surgery, at least in my experience, the VRAM is almost always in a patient that also has had an APR and has a stoma on the other side. So it really is the most challenging patient that we typically face, because you have contamination, a wide defect, and missing tissue. So, when I fix those, for me, that's a retromuscular TAR procedure. I'll keyhole or sugar baker the stoma, and then I'll put a wide piece of mesh and go past the linea seminaris where the flap was harvested. I think the most important thing in those is probably to have reasonable expectations with the patients that they will always have asymmetry, and you probably make that bulge 70% better. But because there's missing tissue, that is the donor site morbidity, and then they will always bulge. But without question, that's the same thing. Another common group would be people with TRAM surgery and breast reconstruction, where there's missing tissue and they will always have a bulge. You can repair so they don't have a hernia, but mesh isn't great. Eating heavyweight mesh isn't great. All these things bulge over time. So I think there's just limitations in what you have to work with. And I think the enterocutaneous fistula, I'm glad you asked me that, because I would just take a second and just say probably one of the things that I regret the most about the biologic mesh trial that we presented is, as often happens as you get older in life and kind of have perspective and finish trials, is that when we designed that trial, I didn't take a moment and think that I think what we showed in that trial is that it would be safe and effective to put synthetic mesh at the time of the enterocutaneous fistula takedown. But what we didn't show was, is that a good idea or not? And the reality is, the harder question that is unanswered from our trial, that I think colorectal surgeons in particular have to deal with daily, is if you're doing an operation where there's contamination during the surgery, but you address the contamination, whether it's a colectomy, a fistula takedown, whatever, and the next time you were to come back, it would be a clean case. Often the right answer is to stage that and don't mess around with the hernia operation. Just take care of the GI problem. As long as you have soft tissue coverage, stop. So I think what's missing from my trial and what should be the next trial is a staged approach. Because if you look at the complication rate in that trial, it's very high. It's a high SSI rate, it's a high overall complication rate. So I think the unanswered question is, if you know that it will be clean next time, should you just stop, primarily close, and come back another day? So today, 2023, if one of the colorectal guys called me with a 8-centimeter hernia and enterocutaneous fistula and they put the bowel back together, I would close primarily, tell the patient, I'll see you in 6 months, you'll have a clean case, and I'll be able to fix you without any issues, much less wound morbidity, less of a chance of a leak. So again, we showed that it's safe and effective to do it, but it doesn't mean that it always should be done. And that's the judgment aspect that doesn't come out in clinical trials. But I always like to kind of throw that out there when I get to talk about it, because it is one of the things that I personally learned from the trial is we might have been going down the wrong path from the start.
Mike, I know we got some questions in the chat, but can you expand that just a little bit about, let's go the other way, when they're getting rid of their ostomy? So, mesh at the time of, we see a lot of, I know we're doing this, but diverting loop ileostomy closure, you take that down, to go to your point, you take it down, although it's been a place that stool has been coming out of. Can you slide a little piece of mesh in there? We use different types of meshes in there, run a quick trial, and it's doable. But what are your thoughts on that, Kate? And then I guess, Vlad, I can see there's about 3 or 4 questions in the chat.
Sure. So that's a great question. So again, I think it goes back to the kind of the fight or flight situation. I think, I don't think it's wrong to put synthetic mesh in those cases. I mean, I think our trial supports that it's a safe and effective thing to do. I will say that today now, I'd probably more lean to, hey, look, just close the thing up. Like, I'll come back another day. Like, it'll be clean. It's so much easier. Maybe I could do it laparoscopically, especially if it's just at an ileostomy site. I think those things are okay to do, and I would never fault anybody, and the data supporting it. But I always like to think now, if they have a peristomal hernia, the stoma is always going to be there. Next time, it's still going to be a contaminated case. So you have to deal with it. But especially in the world of colorectal surgeons, often it won't be contaminated the next time. And so it really does give you the opportunity to do your contaminated surgery and come back another day for your clean case. So I try and weigh that. I basically ask myself this basic question: what will be different next time? If nothing will be different, I go for it. If something will be different and that difference is no more contamination, then I lean heavily to, and it's safe to close primarily. I will do that today, and I think that's been an evolution of thinking for me. You want me to answer some of these?
Yeah, to the effect of what would be different next time, there's a question from Stephen Brandstetter about your BMI goal in peristomal hernia repairs. And I guess also, and this may be different in the United States compared to, say, Australia, how strict are you with smoking as well?
Well, do we have like another hour? So let me just tell you, I used to be psychotic about smoking and BMI, and I've completely changed. Like, the reality is, I don't think smoking matters at all. I think it's better to operate on non-smokers. It's healthier to not be a smoker, and it's smart to be a good doctor and encourage people to quit smoking. But withholding surgery for symptomatic people because they're smoking, I don't think is a good idea anymore. The reality is, if you look at all the data on the harmful effects of smoking, they all come from over-interpretation of large databases like NISQIP, and looking at odds ratios of 2 and 3 and saying that we should stop operating on smokers when the actual effect is from 5% to 4%. And so the actual effect of change, and particularly for smokers, that should really be mesh infections and mesh removals, like a small SSI, a little seroma, a touch of pneumonia that they get over. Like, I don't think we should be withholding surgery for those people. So nowadays, I tell everybody, hey, look, I'm trying to be a good doctor, quit smoking, but if you're not and you're willing to take the risk, let's go. BMI, the reality about BMI is it's not a great number. There are people that have very thin abdominal walls and have BMIs of 40, and there are people that are, a BMI of 38 that have a 7-inch thick abdominal wall. So my restrictions on BMI have gone down tremendously. I have a general concern that we are starting to use things like BMI cutoff of 35 and smoking to kind of just withhold elective surgery for patients. And so I think the one unequivocal issue with being overweight is it's harder on the surgeon. Like, it hurts to retract that. But I think the idea that it is causing some overwhelming negative outcome is probably a little bit overstated. We have several papers that are about to come out that kind of challenge this issue. And so again, I'm not promoting obesity or smoking. I don't think any of those things are good for your health. But as surgeons, we kind of have to ask ourselves, should they be disqualifiers for elective surgery? And I'm challenged that might not be the right answer. I think that's probably pretty controversial, but that's Mike Rosen 2023.
That's a fantastic answer. Thank you. We do show snippets on Twitter, and so I suspect that will hopefully it'll light up a bit when we get that snippet.
If you need a Twitter line, how about this? Mike Rosen said, "Suck it up and just operate." Get that out there.
I've got one last question, and it's kind of the bigger picture of the management of hernias. So abdominal wall reconstruction seems to be evolving into an subspecialty of its own. Whether it's there already, I'm not sure. So how do you see the relationship between colorectal surgeons and hernia experts? And obviously there's a difference also in quaternary centers like the Cleveland Clinic versus more in the community. So what is your take on it now, and how do you think it'll evolve?
Yeah, so first of all, I think one of the most important things is to define kind of when does a hernia become kind of a specialist type of hernia and when doesn't it? Because I think you have to respect, and I want to be open about it. I think for real world general surgeons, and the reality is most colorectal surgeons in the world, they make a living off of fixing hernias. And I don't think that should ever change. I think routine cases should be done by everyone. When things get complicated, I think that's the specialty that kind of has arisen, is people with expertise on dealing with the complex problems. I think where the challenge today is where do you draw that line of when does a patient go from routine to complicated? I think you kind of have to let that happen organically. And I think as we train enough people to do complex surgery, then I think that there's a natural willingness to refer people to people who are, excited about doing some of these complicated cases. As a note of caution, though, in this field, kind of my perspective from looking back a little bit, I would say one of the concerns that I have of abdominal reconstruction becoming a field in and of itself is that I do see a trend around, particularly minimally invasive now with the robot capability, where we are applying advanced reconstructive techniques to more routine type hernias. And we are seeing a lot of the downstream effects of that. So again, where we draw that line and what does all that mean? I do think a specialty of the challenging complex defects are important. I think the relationship with colorectal surgery, I mean, again, like I couldn't imagine doing what I do without colorectal surgeons that we have. I mean, it's vital. Beyond the expertise and the comfort and the ability to deal with the pelvis and all those type of things, the truth is these abdominal reconstructions are taxing, demanding procedures, and being able to have somebody kind of worry about the GI surgery side of it, and then I get to come in fresh and deal with the abdominal wall. I think that collaborative approach is beneficial to the patients. It's beneficial to all of us, and it's kind of a fertile ground to grow with. So again, I see this as we all go into our different expertise, particularly for the complicated things. It's powerful to have that. And I couldn't imagine really the complex colorectal stuff at the same time as complex hernia surgery. Doing that all by yourself it's too challenging.
Well, thank you very much. There's a wealth of knowledge that certainly I have obtained. I think we're over time. There are a few other chat comments. Unfortunately, though, I think probably best to leave it at that.
I'll type it. I'll respond to them. I'll type it. Unless, are we done?
No, you're welcome to respond to them.
I'll shoot some text back to everybody.
Thank you. We do save those, and then we share them on Twitter and things. So thank you very much, everyone. Our next journal club, we have next month off because of Memorial Day weekend, and then the month after, we're having a new session where we're going to feature some videos on the DCR YouTube channel, and we're going to have some experts discussing those videos, and that would be a pelvic floor session. So that should be quite exciting.
Thanks, Vlad.
Yeah, great to see everyone. Mike, thanks for the opportunity to come on and share your knowledge. Obviously, there's not many people that get to share an OR with you, and it's always a treat. So we do appreciate your expertise and for going through everything. And so Vlad, another great job, and to Cleveland Clinic Brethren who supported. Great job this evening, everyone. And Susan, thanks again for all your support in this space. Everybody have a good night. Vlad, have a good day.